What is the risk of these drugs?
I think the downsides are, well, some of these complex patients, let's say that perhaps the patient is bacteremic and we didn't realize that because they came into the ER, they looked like they just had an abscess, we drained it, but it was significant, we felt like they needed IV antibiotics, 7 days should be plenty,
okay.
But on day 3 that culture comes back positive and we can't find the patient. So yes, they still have 7 days of antibiotics on board, but maybe now we're thinking, oh, they need 14 days, or oh, we need repeat blood cultures, and we don't have that patient in front of us. Now that goes back to the types of patients we're talking about. They were going to leave anyways,
right.
Then at least we know we gave them 7 days, so we still feel like that's pro. But in some other scenarios, we need to bring them back in, and now we have some decisions to make. What do we consider that antibiotic active for 7 days, and then give another dose, which would be off-label, switch to another antibiotic? At what point would you add another gram-positive agent that perhaps has a similar mechanism of action when this one is still active? And so there's a lot of uncharted territory because we don't have the clinical work to tell us.
If you had somebody that you knew was bacteremic, with a gram-positive organism, would you use these drugs, or would you use different drugs?
We would use different drugs unless we were in a unique scenario where we couldn't.
So that's the point. In other words, you see somebody with a staph abscess, you give this, you hope the abscess is going to go away after you drain it, right, because you can't really cure these things. What is it, absence of evidence is not presence of abscess? Something like that. But
so close.
like that. But if they come back and now they're bacteremic, this is another kettle of fish, and these drugs are not designed for that. We don't
think. They haven't been studied.
I think it depends on the bacteremia too.
Exactly. There is a lot of it depends.
Okay.
They may well be designed for that, but we're not quite there yet.
So it kind of reminds me of the old Z-Pak days, where when azithromycin was the first game-changing antibiotic that was a 5-day course of therapy. You know, you discharge a patient on it and they'd go, there's not enough pills here. And it really took a lot to teach people. But what we started observing is people would start giving a second Z-Pak, and pretty soon. And so, you know, you don't want to go down that path again.
A colleague of mine says you have to have the intestinal fortitude to not give another dose for a week, no matter what.
You know, patients expected to get better overnight with this new short-acting drug. And it sometimes just doesn't happen.
That's a good point. Patient education is very important, and we found that out when we first started infusing this, that we need to educate the patient that just because you're only going to get 1 dose does not mean you're going to wake up tomorrow, and if your leg has been red for the last week, it's not going to be completely not red tomorrow. So setting appropriate expectations that you should start to see improvement in 48 to 72 hours. You won't see a total improvement for 7 days or even more.
I mean, I do remember several people, lay people, coming to me with older therapies, which were known to be effective. They said, I had XYZ, I took my antibiotics, and I'm still sick. And I would say, well, when did you take the therapy? Oh, this morning. Why am I not mirabile D2? Why am I not cured? So it's both, it seems to me, practitioners and people getting the therapy, right?
Well, but I think she raises a good point. The novel long-acting glycopeptides are not better than the currently available therapies. They have a different profile that may or may not offer a benefit to your patient or your institution, but they're not better in vitro, they're not better in clinical trials. They're not better, they're just different. And you have to decide if that distinction is a difference that matters to you or not. In addition, you know, just for the sake of balance, we also have now a new oral fluoroquinolone that has anti-MRSA activity that's recently been approved. And it's unique that it also has gram-negative coverage. So now you have an anti-MRSA fluoroquinolone. Again, whether that's good or bad is going to determine, well, in terms of that spectrum of coverage, you know, there are some patients where you're actually worried about gram-negatives as a co-infector or the only pathogen in their skin and skin structure infection. And there are some where you're not. So again, you need to individualize and think about these things, and you can't say, well, this is always going to be the right choice or this is never going to be the right choice. And I think around this class of drugs, these long-acting agents, you know, the reimbursement scheme we have in this country for who pays for what about drugs and where really complicates the decision-making process about how to apply them, because if you're admitted it's going to be covered by a DRG, and then my pharmacy director never wants to pay out of his silo budget for a week's worth of antibiotics if the hospital stay is supposed to be 2.5 days, and the outpatient payer should be covering the tail. And the same way in the ER, they're never going to let the ER spend that much money on an antibiotic without some other authorization.